Welcome to our ARVC Masterclass. Listen up.
All right, we're diving straight into your ARVC Rapid Review. This is a high-yield blitz, so strap in and try to keep up.
First up, what is ARVC? At its core, it's genetic sabotage, a total failure of the heart's desmosomes, the glue that holds everything together. What's causing it? It's primarily mutations in genes like PKP2 and DSP. You have to know those letters. The pathophysiology? Think of it this way. The right ventricular wall gets replaced by fat and fibrous tissue. We call it the fatty wall. And what does that lead to? A thin, dilated RV and, you guessed it, lethal ventricular arrhythmias.
Now, on the EKG, your first clue, your first hint is going to be T-wave inversions in leads V1 through V3.
But here's the big one, the money shot. You have got to keep your eyes peeled for that highly specific and diagnostic Epsilon wave.
And for the clinical pearl, if you ever see a patient with woolly hair and calluses on their palms and soles, your brain must scream Naxos Disease.
Management? Simple. Stop the exercise, start the beta blockers, and get them evaluated for an ICD. Know the wave, find the fat. Let's go.
Excellent. Now, before we dive deeper into the pathophysiology of this fatty replacement, we must pause for our mandatory international medical disclaimer.
This content is for educational purposes for USMLE and international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
Okay, Sarah. ARVC is, well, it's a truly unique structural disease, isn't it? The heart muscle literally disappears, and in its place, we find fat. For the boards, the EKG is our most powerful tool to pick this up.
So let's start there. What is the single most specific finding we are hunting for right after that QRS complex?
That would be the Epsilon wave, Dr. Collins. It's that small, low-amplitude notch, almost like a little wiggle, that appears at the very end of the QRS complex. You're really looking for it in the right precordial leads, so V1 and V2. And what it represents is the delayed activation of that diseased, fatty right ventricular wall. Of course, we'll also often see those T-wave inversions from V1 to V3, but only when there isn't a right bundle branch block to explain them.
Exactly. The Epsilon wave is the electrical signature of ARVC. Now, the latest guidelines really emphasize that, fundamentally, this is a disease of the desmosomes. These are the proteins that act like glue, holding the cardiomyocytes together. So when this glue fails, the cells literally pull apart, and fat just fills in the gaps. So which key mutations should students have locked in for their exams?
Well, the most common mutation by far is in the PKP2 gene, which codes for plakophilin 2. But for the really tough advanced questions, you have to know Naxos disease. This is an autosomal recessive form that's caused by a mutation in the plakoglobin gene. And these patients present with a classic triad. 1, they have ARVC. 2, they have this very characteristic woolly hair. And 3, they have thickened skin on their palms and soles, which we call palmoplantar keratoderma.
Outstanding clinical correlation. Now, for everyone watching, I have to stress that the diagnosis is complex. It relies on the formal task force criteria, and we'll have a link to that for you in the resources.
These criteria, they lean heavily on imaging. We are looking for crystal clear evidence on an echocardiogram or a cardiac MRI that shows a dilated right ventricle with very specific regional wall motion abnormalities. This structural evidence is absolutely key. Now, Sarah, speaking of stressors on that wall, why is exercise restriction so incredibly critical for these patients?
It's because that mechanical stress, the pounding from exercise, on those already weakened desmosomes just accelerates the cell death and the fatty replacement. Things like high-intensity sports, they dramatically increase the risk of ventricular tachycardia and sudden cardiac death. The guidelines are completely unequivocal on this. If you have a definitive ARVC diagnosis, competitive and high-intensity sports are absolutely forbidden.
Precisely. So management is all about one thing, preventing that lethal arrhythmia. We use beta blockers, something like sotalol. And for our high-risk patients, the ones with a history of syncope or sustained VT, an implantable cardioverter defibrillator is the only proven life-saving therapy we have.
And that brings us to our question of the day. Have you, personally, ever identified an Epsilon wave on a real 12-lead EKG? I'm asking because they are often incredibly subtle, so easy to miss if you aren't actively hunting for them. Tell us about your findings down in the comments.
All right, Sarah, let's lock in the ARVC rules for good. It's time for the memory chant.
Ready? Here's the beat. Fatty is the wall. Epsilon is the call. RV is thin.
VT will win.
And woolly hair is Naxos.
Locked in, fatty wall, epsilon call.
Naxos triad.
Got it.
Excellent. We've covered the muscle, the balloon, the stone, and now the fat. It's time to integrate it all. Make sure you subscribe to Clinical Crash Course and join us for our series finale, Module 6, Rapid Review and Heart Failure Decision Tree.